I'm talking from Helsinki, Finland, and I have asked the technical assistant to move my presentation forward. So can we have the next slide, please? Okay, thank you, great. So I'm very happy to be in this prestigious meeting, trying to give you a bird's eye view of the ICT infrastructure and the approach to electronic health records and the secondary use of sensitive personal information in Finland, which is, of course, the post-Nokia country, which at least to some degree explains why Finland has ranked at the top of international comparisons of healthcare information technology for a few years now. Finns, maybe because we were so used to mobile technology many years ago already, are active users of their own health information. They are very keen on electronic digital services, and they also want to have at hand their own health information. And I will show you some examples of this later during my presentation. So this is the bird's eye view of the systems architecture for healthcare and social welfare in Finland. Time doesn't allow me to go down to all the details, but this just gives you, I hope, an idea that on the national level, we have set common goals and common targets for healthcare providers and also social care providers during the latest years, so that all the information that's being generated and collected in our service system, which is mostly public, but has also a private component, that all this information would be available in national databases so that anybody who has the legal right to access to this data has that readily and without too much of technical hazards at hand. And this applies to healthcare providers, healthcare professionals, everybody who is a client or a customer or a patient in the system, but also researchers and organizers, policymakers for aggregated data to allow more efficient planning and governance of the service system. So it looks nice, but actually it has taken a long time to create this vision and make it happen. It's not perfect yet. We still have problems with interoperability, but there is a strong will to take even more steps forward. So honestly, it has taken almost 40 years to create this system, starting from the first patient information systems. But really the milestones during the development of the national system have been the creation of the Kanta patient archive architecture, then allowing e-prescriptions, which is now the mainstream for drug prescribing in Finland, and then the patient data repository production phase. So the legal basis was finally materialized as the production phase about 10 years ago. And the latest additions, of course, have to do with the GDPR, so that the secondary use of this information would be made possible, but I'll come back to this a little bit later during my presentation. So it all started locally. Our health and social care system is fairly decentralized, but then came the regional systems, and they should be merged to a national system. We are still far away from that goal, but the final common minimum denominator is the Kanta patient and latterly also social care customer data repository, which is mandatory for all care providers in Finland. And actually nobody wants to operate without access to this database. So there is, of course, the technical requirement to this, but I really want to emphasize that all this could not have happened without the legal basis, the legislation that's being necessary to make this all happen. And it has also taken not that much, roughly 20 years from the earliest new acts and decrees to the latest additions. And it has been a evolving legal basis, and we still need to address some of the gaps in this legal basis, particularly when it comes to the integration of data collected in biobanks and the Genome Center, which is being planned in Finland and needs a separate legislation on how genomic information could be added in a safe and secure way to this database. Okay, a few words more about this Kanta, which is the real innovation in this system. So it is an entity of digital services which brings together patient data, technical data, prescription data, personal health records, and the latest addition is the social care data, which is not still completely there, but it is on its way. All this data is gathered in a national data bank, which is available to healthcare professionals nationwide, and also to citizens who can browse their own medical records and prescriptions and order repeat prescriptions in the online service. So this web page, which is available to everybody in Finland, has been voted as the number 1, 2, or 3 most popular website in Finland many times consecutively. So we are 5.5 million in this country. And during the last 12 months, there have been almost 3.5 million logins, and roughly 1 million single persons have approached the Kanta pages. And this, based on my own personal experience, I can say is pretty handy. It's easily accessible and reveals most of the medical records to you. There is an option for you to limit the visibility to healthcare professionals, but there is a certain minimum number of information which is available of everybody who has ever approached our health system, be it private or public. So I also mentioned the latest addition to the legislation, which is the secondary use of both health and social data, plus national registries from other collected based on separate legislations for separate purposes. So this act is effective since May 2019, and we have a new data permit authority in this country called FinData, which operates in close connection with our National Public Health Institute, THL. And this new authority and the legislation ensures that authorities, institutes, and companies, academic researchers, other research organizations can access the health and social data in Finland according to certain rules and procedures which are operated by this new authority called FinData. So this new authority has the governance over the permits and data requests that have to be submitted to this authority, regardless of the purpose of the need. This new authority reviews these requests and then gives you the permit. And it also takes care of the data collection and processing and allows you to work on this data in a secure remote use environment. Actually, this is a much more complicated system, but this is a short way to describe the responsibilities and services provided by this new authority. And this legislation went through our parliament after the GDPR was in action and was found to be totally compatible with the GDPR judged by the Constitutional Committee of the Finnish Parliament. So far, we have not found any major practical problems either in the interpretation of this legislation versus GDPR. Well, then came the COVID crisis, and Finland being in the northeastern remote corner of Europe, the epidemic hit us 2 or 3 weeks after the other neighboring countries, and that's one of the main reasons why it never really became that bad. The epidemic never really became that bad in this country. The other reason for that was that the special powers legislation was put into action in the early phase of the epidemic, and it gave the government very strong powers to prevent the spread of the virus, which totally changed the story by mid-April. So this, of course, was a stress test to the digital service system that we had in the country. What we saw was the rapid development and uptake of symptom self-assessment tools. There are basically two of those in the country, one which is provided publicly for everybody, and another one which serves the capital region, but they talk to each other. Then in August, we got the Koronavilkku tracing app operating. Over 1 million people loaded it during the first 24 hours when it became available. And now we have more than 2 million downloads in the country, which is 40% of the population. And what we know by now is that of the new COVID crisis, roughly 30 to 40% do announce their infection through this mobile app to anybody who has been close enough to be in the risk of a contamination. It doesn't show anything about your personality. It doesn't tell anything about where that happened, but it has remarkably speeded up the tracing functions. Of course, as has been described by some of the previous speakers, there was a frog leap of digital service provision. We in the central government don't exactly know how much this happened because of the decentralized governance of our health and social care system, but based on some interviews and data collection from hospital districts, we would say that particularly the hospitals took over the digital services. In primary care, mostly what we saw was the reduction in visits, which was not entirely covered by the increase by digital services. A little bit surprising, but that seems to be the case. Our hospital system is very well connected electronically, so we were able to real-time monitor the ICU capacity issues and some other, but not all service provision capacity and performance measures, to be honest. Since I have spent some time describing the Kanta and also the FinData secondary use authority, I wanted to emphasize that one of the advantages of having all this data at hand is to be able to analyze both more or less directly or in real time the effects and lateral effects of the epidemic on population health and socioeconomic outcomes. But what we saw was that we don't really have that good understanding of how people behave and how the services are being redirected to those who would be mostly in need. I will come back to this in a minute. And of course, that everything leaves a digital fingerprint that allows for a whole lot of translational and clinical research opportunities, both now and in retrospect. And I think this is my last slide. So I think that digitalization, as we all know, changes, but also allows for new operating modes. And the crisis has revealed potential, but also that there is plenty of room for improvement, even in a country like Finland, especially in national level interoperability. Customer-oriented and reliable online services promote patient satisfaction, as well as the effectiveness of services. That's a win-win situation for sure. But as I already mentioned, real-time monitoring of health system performance must be improved. Proper resource allocation, ensuring essential services, patient safety, and so on. We could have done much better. And this is one of the lessons to be learned, even for the central government in Finland. And we try to now reshape our legislation and improve the interoperability of the health patient records and so on to even be better prepared for the potential next waves of this epidemic and any other exceptional situation that might need better governance of the system. And I just wrote here, the last line is the European health data space. We will see what will come out of that, but definitely there is a need for even cross-country better performance. And on the right-hand side of this is just the digital inclusion concept. Because I think that if we are going to rely more and more on digital services, as we are, and people do request that, they want to have digital services, even in health and social care, because they are so used to this kind of services in other fields in society. We have to remember that not everybody can make use of the digital services. And how do we then improve digital inclusion is the responsibility of the public health authorities. Thank you very much.